Hello and welcome, everyone. My name is Renee Garrett, and I'm your speech therapy PD podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for zero point 0.1 ASHA CEU. Here are the disclosures. Stephane Ratway is a paid employee of the UHealth Jackson Christine Lynn Rehabilitation Center. Stephanie is the president-elect of the executive board of the Spinal Cord Injury Support Group of South Florida and co-lead of the Women's Spinal Cord Injury Support Group. I am the owner and founder of Brain Bridge Connect, and as the host of this podcast, I do receive financial compensation from Speech Therapy PD for this and other educational webinars. I am also the president-elect and secretary for the Communication Disorders Foundation of Virginia. Now we welcome our guest, Stephane Philippe Ratway, MS, CCC, SLP, who received her MS in Speech Language Pathology from Florida State University in 1993. She has over 3 decades of experience working across the healthcare continuum, including trauma ICU, acute care settings, rehabilitation, and home health. Since 2018, she's worked primarily in the Spinal Cord Injury Rehabilitation Unit of UHealth Jackson Christine Lynn Rehabilitation Center, serving patients with different levels of spinal cord injury and varying degrees of paralysis. Over the last 4 years, she served as the primary investigator in research on pulmonary rehabilitation and spinal cord injury. In 2023, she received the Craig H. Nelson Foundation Allied Health Professional Research Award of ASIA, which funded her research. She's delivered numerous presentations at conferences and currently serves in the Leadership Council of the Spinal Cord Injury Support Group of South Florida and on the Women's Support Group. Stephanie, thank you so much for being with us and sharing your time and your talents, as they say.
Thank you very much for inviting me, Renee. It's a pleasure being here and sharing what I know, my experience.
Well, talking to you, I know that you know a lot, so I'm excited for this. Can you tell us how you got started? What led you to the field of speech language pathology?
I think a lot of us have this sort of shared experience where we were first introduced by speech therapists themselves, right? So as a kid, I grew up with a lisp, and I thought I spoke pretty well. I was fine until I got to middle school when kids get a little cruel and tease a bit. So I also had an overbite, or an open bite, actually. It was the malocclusion. And getting braces on, and the orthodontist sent me on over to a speech therapist to correct the frontal lisp. And I thought, oh, wow, this is really interesting. So when it came time for me to choose a profession, I naturally sort of went to that. So that's my story. I'm sticking to it.
I don't miss the orthodontia days of that era. For those of you who are over a certain age, our experience with orthodontia was quite different than I've watched my own children have.
Absolutely. When I see people going back as adults and getting the Invisaligns, I was like, what are you doing?
Because they don't do the molds like they used to with the tray that they sat in your mouth and leaned you back and you thought you're going to die from aspiration of cement. It's quite different.
That is very much so. And I'm happy for that, because I don't think we deserve that treatment.
No, and they leave you there by yourself, and it took forever for it to gel, and so you're laying there. I'm probably like, I don't know, 11 years old, thinking, oh my gosh, no one's coming to get me.
And I'm gagging. Oh dear.
Yes, exactly. Oh my gosh, no one prepared you for that. Hopefully our patient care skills are much more refined than that now. We actually try to talk our patients through what we're doing when it comes to things like instrumental exams, so they're not terrified like we were.
And it's funny because I recently had one of the things that I do at work is to help introduce some technologies to patients who are paralyzed. And there's a really interesting technology now that is called a mouth pad. I don't know if you've heard of it, or if any of your subscribers have heard of this, but just getting and I got one done for myself, and just getting the imprint was a completely different experience. It was all digital, it's just picture.
Hmm.
It was really cool.
Yeah, well, it is very cool. So let's start out by just talking about kind of how we as SLPs need to be involved in that arena of spinal cord injury patients, and we'll kind of evolve from there. But like thinking about the assessment and how we are in that space, because a lot of people I don't think really like you mentioned before, really realize or recognize that we need to be involved very early on and also throughout that continuum of care.
Yeah, I think that's something that is not really stressed enough. Not many people in our field really understand what we bring to these patients and how valuable those skills are really to help them when they're first in the trauma center. If we're talking about traumatic spinal cord injuries, their you know, lack of understanding, number one, of what's happening. So there's a lot of concurrent diagnoses with traumatic spinal cord injuries. So you encounter a lot of traumatic brain injuries as well. And sometimes, especially the more mild to moderate TBIs, are not necessarily documented.
Mhm.
A lot of life-saving measures that are happening with someone when they're first in the trauma bay. And so there's a lot of like MRIs of the spine done, of the abdomen, any other like, polytrauma issues. And so the patients have to be stabilized. And if there isn't an obvious sign of loss of consciousness, for example, or more overt injuries to the head, unfortunately, that gets overlooked. And so the paralysis is first and foremost seeing the, life measure of stabilizing patients and making sure they're able to breathe on their own, or if they're on, if they can't, they're trached or, endotrached and that kind of thing. So, oftentimes the speech therapist is called in as a consultant to check for swallowing. Can this patient, once they're stable and they're decannulated or the ventilators are weaned off, can this patient start eating? Yes or no? And then if it's a yes, we sign off and move on. And that's something, and we miss the opportunities to really have an impact on their recovery.
Yeah, and I think that's such a great point because a lot of times the TBI part of it is not documented. And we start to see these signs and symptoms if we're involved. But often, I know in my career in inpatient rehab, starting out as a new clinician, I typically would see those patients for swallowing, like you mentioned. Very rarely did that continue on with cognitive issues unless I was with them and saw, okay, this is not, or, someone that was close to them, a family, a significant other, a coworker, or a friend would say, this is not, their responses are different, or they're not communicating in the way that was typical for them prior to their injury. And then you got to have that in to keep going. But I think it's a difficult thing for us to not have that and not know who these people were prior to their injury, because we might think that that's their typical form of communication, or maybe they just were a little forgetful, or maybe they always had an executive function problem that kind of mimics like an ADHD or an ADD premorbid diagnosis. So how do we get in there and kind of start assessing that and looking at those cognitive communication things versus only being involved in the aspects of swallowing?
I think for my practice, especially in the years that I've been in spinal cord injury, I think I've had to uh, work on getting away from the medical model
Mhm.
practice where, and that's something that we are trained to do, right? You assess, and then based on the results of the assessment, that's where you sort of start your goal setting and that sort of thing. And typically the assessments, there is a reason for the assessment. There's a diagnosis that is given, that etiology. Okay, so that person has a traumatic brain injury. Now the speech pathologist needs to go and assess. What I find most often is that there is no diagnosis of TBI. And what we have are, like you said, sort of anecdotal um,
Mhm.
reports from caregivers and loved ones to say exactly that they're slow in responding. This is not the typical way of communicating or even reasoning and that sort of thing. The other thing also is to sort of understand the nature of a spinal cord injury. It's because we're talking about an injury that affects the central nervous system. This is like and the peripheral nervous system. So you're talking about, this is brain tissue that's going all along the spinal column. So the control of the autonomic system. So we're talking about blood pressure, temperature regulation, that sort of thing, can negatively impact cognition. If you think there's not enough infusion of blood because the blood pressures are low, and that's what happens
Mhm.
with high injuries, typically from thoracic level 6 and up, you have disturbances of the autonomic system. So they're having a hard time maintaining the blood pressure. So the perfusion to the brain is reduced, resulting is a cognitive deficit. The medications impact their cognition. And then the other thing that we see is an impact of all the emotional things, right? The social emotional aspect of a sudden catastrophic injury uh, impacts the cognition as well. The patient's executive function, the ability to attend to new information and retain the information. All of those things impact their overall cognitive function. And so I've had to really step away from how I was trained and how uh, the practice of speech therapy all these years, where I looked for a specific issue stemming from an organic injury, right? Or a stroke, for example. If it's a right-sided stroke, I know exactly what I'm looking for. I know exactly what kind of assessments to give. And then, sort of based on the percentage of deficit, I start
Mhm.
my goal setting. Whereas for in my practice in spinal cord injury, I've had to sort of shift all of that and look at the patient holistically to really see how they're navigating through um, the injury. And then really they have to learn all this new self-care in order to rehabilitate, for lack of a better word. So it's a long answer, but
No, it's a great answer because I'm thinking as you're talking and thinking about the patients that I've been able to serve. Again, this was, in the beginning of my career was where I saw most of those patients and that inpatient rehab and some in LTAC as well. And so we think about, like you mentioned, the low perfusion to the brain. So we're thinking, it's hypoxic at that point. Maybe they did have a trauma that was a mild concussion or even a mild. I don't like using the term mild TBI. Honestly, it's just TBI is TBI. Some are worse than others, but TBI tends to really impact patients, and it makes sense that when you look at the statistics of what happened to cause a spinal cord injury, it's what? Falls, motor vehicle crashes, and I'm sure you have other sports athletes, sports related injuries, and I'm sure you have other categories as well. But for me, I think that would probably be the three that I would think the
yeah,
most. And so it would make sense if you had a fall. If you have a spinal cord injury, your head is probably involved as well. And I like what you said too about thinking about how, your signals in your brain, your motor, and even your sensory, they're triggered down through the cranial or through the spinal column and out to all those nerves that activate our muscles and are it's a complex process, and I think that's part of the reason that um we're not maybe as present as physical therapy and occupational therapy in that space.
Right. Right. Yeah. Yeah. It's typically what I mean. And when I was asked to join the SCI unit, I was like, what? I can consult like I've always had, or if someone was intubated for a very long time, I saw them for phonation or, breath support, for example, that, and then signed off. And they said, no, no, we really need you. We're seeing some things. These people have to learn all this new information and they're not retaining. There's something there that's missing. And really, when you look at the nature of a traumatic spinal cord injuries, yeah, it's high velocity, right? Fall, motor vehicle accident. We've had several young injured patients from sports. It's bizarre, a gentleman who became a quadriplegic it from a tennis match that he was having, and he was dodging to make a point, and unfortunately fell in a way that he injured his spine, cervical spine. So all of those things involve, high impact, high velocity, and sudden stop injury, which we know very well the brain is definitely involved in those things. Absolutely. So
Yeah.
it's
I
it's
always describe that brain as sitting in a bowl of jello, and when you stop it, it's gonna go flat, flat, contra coup, coup
yeah,
contra coup. That's one of the first things I think I learned in my neuroanatomy class way back 100 years ago.
right. If you remember that coup contra coup, absolutely, yeah.
Yeah, and I've certainly seen, like you said, patients who a lot of times and I go back to inpatient rehab because again, this is where I saw it most frequently. When I was working in acute care, I think the only time I ever got consulted would have been for swallowing for someone who had been intubated for a long period of time, or on occasion I might get someone who had been a quadriplegic for a long period of time and had a needed cough assistance, and they would call me for whatever reason. I'm like, oh, I don't what
Right.
all respiratory therapy. But I
Right.
think, I go back to that and I think about those times because a lot of time we may not, as SLPs, may not have been consulted on that initial inpatient rehab stay. It was because they were working with physical therapy and occupational therapy, and they noticed that these things you're talking about, and we can kind of dive into that so that people understand the new information that these patients are having to learn about their ADL, so their self-care, appropriate transfers, in some cases, pressure relief if they're at the point where they've gotten, a mobility device. They may need to know about all those things, so we can kind of dive into that, I think, as well, because I don't know that people really, unless they've worked with patients with SCI or been a family member or caregiver, whatever, they may not understand what you mean and what that looks like for learning all these new things that they have that the patients need to know.
Yeah, and we're in an era where a length of stays are getting shorter and shorter, so they're having to learn the same amount of information that they had 3 months, for example, to learn
Mhm.
patient rehab facility, and now they have maybe 23 days.
Or
Yeah,
2 weeks.
eras. Yeah, for sure, it's what we have. And so it's a challenge in that way. And when they're first, even when they've stabilized enough from the acute care side, and now they're transferred in the inpatient rehab, we spend the first really 2 weeks just trying to stabilize their blood pressure when they're sitting up.
Mm.
It's one thing that we take for granted. The spinal cord has so much to do with our system that keeps us alive. When you put your car in neutral and it's just idling on, that a lot of those involuntary functions are just going on, and all those signals from the brain to and from the body, that's all going through the spinal cord. And so oftentimes with patients with high injuries, their ability to even support their consciousness when we sit them from supine to sit is an issue. They lose their blood pressures, bottom out, and we get people passing out. So again, that poor perfusion of blood. And so all those things impact really their ability to learn, to attend, and then to actually retain, understand the information is being taught. And to that point, the information is critical because mortality and readmissions of in hospitals are typically not because of the primary injury, the spinal cord, but because of the secondary issues or the other risk factors. So when you talk about weight shifting or offloading of pressure, that's something that they have to remember to do every few minutes. Otherwise, their skin is compromised because you're sitting in one spot. We move and shift without even thinking because our bodies signal that it's time to relieve pressure. They don't get those signals anymore. And so they have to think or use compensatory strategies or other things, which is where we come in a lot of times to help pressure relief. They have to remember to catheterize themselves every few hours, right? That's part of their ADLs. When I have to urinate or my bladder is full, I know because my body gives me that signal. They don't have that anymore. So they have to think about staying on schedule. Otherwise, that can be life-threatening. Same thing with bowel management, same thing with temperature regulation. I mean, there's so many things that are no longer done because it's a reflex or it's intuitive. These are things that one has to think about and have to remember. And so if you're having difficulties learning and then retaining, that's an issue that can actually impact your ability to be independent and really your life. So it's a serious thing, and I think that's um, one of the reasons why I'm so passionate in spreading the word that speech therapists are definitely valued in that with that population. It's something important.
So what kind of strategies would you say and it's kind of I wouldn't say a difficult question, but we all know that, every patient's different and not all strategies are a one size fits all, but and trying to integrate what you're doing into that other home environment or, if someone has to go to skilled nursing or long-term care.
I think it depends on the severity of the cognitive deficit
Mhm.
and also where they are in that journey of rehabilitation. Because again, like I mentioned before, there's a lot of emotional baggage, a lot of emotional stuff that they have to deal with. I think the most effective strategies that I found working with this population has been what we do best as speech pathologists is simplifying information, breaking things down. Oftentimes, I use a lot of visuals. I use games to teach, and then we implement strategies like putting alarms. There's a couple of great apps that actually you can speak on the task and then set it to alarm. So when it the alarm goes off, you can hear your voice saying, "Hey, time for pressure relief," that kind of thing. So there's, for example, I'll share one of the games that I actually love to do. So one of the things that we teach patients to do to help with skin protection and integrity is skin inspections. So they have
Mhm.
to daily skin inspections, especially in the areas that they do not feel as well. So the paralyzed limbs, for example. And so you can't rely on how, some if you have a bruise, something hurts. you can't necessarily feel that either at all or very well. So the perception is a little bit distorted. And so you have to use your eyes and you have to use either a partner to sort of help inspect your skin. And so in order to get this into more of a habitual practice, we play games. And so a few times, the first few weeks that I'm teaching this, or a few days that I'm teaching this, I have these little red stickers that I place on patients, and then they have to find them all during their skin inspection. And then they get points for each ones that they find. And at the end of that session, we, get a reward. So it's sort of like, what we've done working with pediatrics, right? And then,
Well, yeah.
uh, you know, adolescents and that sort of thing, but it actually works and it makes it fun. And then we're able to repeat that task until it becomes a habit, and then they don't need those red stickers anymore. Those red stickers I place in areas that are high risk, right? So areas where bony prominences are closest to the skin. So they have to attend. So here's that attention again in those
Mhm.
areas. And we repeat that task over and over again until they get it right. So that's one of the things. So repetition works really well. Breaking down information works really well. Teach back is another one that I use a lot because these guys can reason with you, So yeah. So I don't know if
Well,
that's
and I think the really important thing when you're thinking about the bony prominence, and again, if it's, if we have listeners on or people who are on with us on the live, they may not realize that the importance of why we need to be looking at those bony prominences. So can you kind of explain that as well?
so we've all if we've practiced in healthcare facilities, we're all familiar with wounds or
Mhm.
injuries. And so there are certain areas in the body that are more sensitive or more prone to pressure injuries. The sacral area, so in your
Yeah.
sit area, in the heels is another area. The areas that are around the knees. So anywhere that you can think of. So for example, my elbow, the
Mhm.
bone is very close to the skin. There's not a whole lot of padding around that. So imagine if you're sitting on an area where there's a bony prominence. So if I were to lay my elbow on the table and not move it for a while, after a while, there's going to be a development of some injury of that skin. And if I relieve the pressure, if I take my elbow off of that hard surface, then the blood is able to circulate all around and the skin is fine. So with someone who has a new paralysis, they can't easily move. And so, they're sitting or laying in one position for a very long time. And so we teach pressure relief of how do you shift, using a mobility device, for example, a power chair can shift back and forth. If they're in a manual chair, we teach them to lean one side or the other or forward, that sort of thing, to pressure relief. That has to be done every so often. And then looking and inspecting the skin at the end of the day to make sure that the skin tolerated the activities and that you didn't get any bruising or injuries or scrapes or anything like that. Because again, you can't intuitively know because those signals are not traveling to your brain necessarily. So
Yeah, I think a really interesting experience for me was doing wound care rounds when I got to cover the LTAC floor because that's what I learned. It doesn't take very long for the skin to break down in those patients. It could be a matter of a couple of days if the pressure, the friction, the stress on the skin isn't changed. And we think of as speech language pathologists, we're not really, do we need to know that? Or maybe that's not our area, but it is because again, you're the person who's going to teach the use of visual aids, those use of strategies like you mentioned, the app in the phone or the reminders in the phone. we're teaching even the old school way of writing it out with a Sharpie on a whiteboard. We're teaching those things. And so we need to be mindful of what we need to know in order to teach that strategy or that skill, and working with the multidisciplinary team if we don't know, to figure out, okay, physical therapy does this and knows this, occupational therapy. Your wound care nurse is such a great wealth of information. Oh my gosh. As scary as I found that to be when I was a new grad, new clinician. I'd never looked at pictures of wounds and watched them stage wounds. And it was kind of like, ooh, but I learned a lot. And I
Yeah.
learned that's really when it became more about the holistic care of the patient, how nutrition plays a role, which brings us back to the swallowing and how we work with the dietary, like a registered dietitians on the team. So yeah, it's really, I think for me, besides traumatic brain injury and stroke, spinal cord injury patients are the ones who really the holistic care from the beginning is just incredibly important.
I think that the payer sources are also recognizing that. That's one question that I get a lot when I will lecture. And I'm actually mentoring a therapist in Alabama now who's starting the same sort of program that I developed in Miami. But one of the things that I get, or I used to get, not so much anymore, is, but if there isn't a TBI diagnosis, isn't your service being denied? And actually, I've never had a denial of services, even if I have given a formal assessment and the patient's scores reflect uh, within functional limits in their cognition. And it's because I think I remember when I was putting a lecture together a few couple of years ago, and I looked at the Medicare guidelines. There's actually a couple of statements in the new reformed guidelines that talk about patient-centered, patient-relevant assessment and treatment. And so patient-centered is what I focus on when the goals are being developed, when I sit and work with patients, because all of that they need to learn is relevant to their rehabilitation. And so we developed a tool in Miami that we can measure the learning. So we have at the beginning, we do an assessment of self-care knowledge after SCI. And then at the end of their stay, or close to the end of their stay, we reassess them. So we administer this test. It's 33 questions, very simple, and then we score their independence in the education. And so with having that sort of has helped justify the services of the cognition, right? Cognitive deficit services in the spinal cord injury unit. And with those patients who score within functional limits, for example, if I give the MOCA blind, for example, which is a good one to do with folks who are not able to do the writing portion because of the paralysis, I list the medications that negatively impact. And then I also show the reduced knowledge of their self-care. And that helps to justify my services there.
Well, yeah, and medication is such a great segue because a lot of our patients, maybe they weren't on medication at all, or maybe they took medication, like a Motrin or Advil or whatever when they had a headache prior to their injury, and now they've got a regimen
Yeah.
of medications. They've
Yeah.
got to, not only keep up with the medication itself, the dosage, the frequency, uh, monitoring for possible side effects. So it's a lot. So again, I think when you're talking about new learning, we think new learning is like, oh, well, maybe they're in a wheelchair and they have to figure that out, or, oh, now maybe they can't go back to the job that they did before. But, we're talking basic life things, medication regimens. Who's preparing food?
Mhm. Yeah. And also with medication, there are some medications that have pretty serious cognitive consequences, right? A lot of,
Hmm.
and a lot of these are used with this population. The neuropathic pain medications,
Yeah.
things with that control spasms. Uh, there's the side effect is drowsiness, reduced alertness. There's even a medication that, if it's a long-term use medication for to help manage the bladder, it's clearly listed that one of the side effects is long-term use is dementia. You know,
Hmm.
so it's quite, yeah. There's a lot that impact that, and they do have to learn their new regimen. They have to learn when to take it. They have to remember to take their meds. Yeah, so there's a lot. Yep.
We do have a question. Is the assessment that you developed in Miami available for SLPs who work in other locations? And if so, how do we obtain that?
So it's specific to Miami. It has not been published anywhere else. We're in the process now of sort of looking at an IRB where myself and a researcher in the model system, we're looking to see how we can make this more. We're trying to gather data to see if it's in its current ideation. Is it something that we can publish to be make available? So it's in process right now. So it's only available in Miami, unfortunately. But it's one, I think that if you're interested in adapting to or looking at, I'm happy to jump on a call. I can share my information just to give you guidelines on what to look for, some questions, and how to develop your own. I'm happy to do that.
Yeah, and I think that's great. I hope you guys are able to get that published. I know that's a huge undertaking to get everything normed and all that. Just dealing with all that is a lot to get a new assessment out there. I want to circle back though to talk about pulmonary health management because we kind of talked about that in terms of dysphagia, but you know, what's the importance of pulmonary health management for these patients?
Hugely important. When you look at the data, it's actually pulmonary respiratory complications. It's one of the highest risks after traumatic spinal cord injury, uh, which can lead to mortality. It's actually one of the greatest risks. I forget the exact number, and I should have refreshed my memory before jumping on this call, but it's quite high. And
Mhm.
so typically, you have, uh, depending on the level of injury, you have compromised diaphragm,
Mhm.
and or also have compromised the muscles that sort of help with exhalation can also be compromised. So you have issues with secretion management, especially early on in the acute phase of recovery. You're getting a lot of parasympathetic responses, which increases secretions. And so these patients can't necessarily cough. They've lost that. And so secretion management is a huge, huge problem that we can help with. Absolutely.
Yeah, and I know the old I hate this, and I only say this because this always helped me remember when I was a younger clinician, but C5, stay alive.
That's right.
Yep.
Keep 4 and 5, keep the diaphragm alive. That's it.
Yeah, yeah, and when you think about that, I think this is a population where, again, our role early on is often overlooked if the patient isn't stable. So we're looking at, in spinal cord trauma units, for example, like a trauma ICU or a neuro ICU, we may not be the first consult or the early on consult because the patient is not always super stable at the beginning. And so there were times when I worked at the trauma center where we would get consulted, and then the patient would actually get removed from our caseload. That wouldn't be my discharge or the other SLP's discharge. They would get removed because they had a change in status that was a higher level of care was needed and they weren't appropriate for our services. Have you found that to also be the case for you guys in your unit?
I have. It's getting better though. I think there's more education that we've done in the trauma center. We're a level 1 trauma center where I work. And so we actually get consulted pretty early on. And we've even been able to, for those folks who have failed extubation and vent weaning, they actually involve us in helping with weaning. So that's actually better. We are involved early on with respiratory muscle training, even with patients who are ventilated and trached. We slap that EMST right on the tray and do some postural manipulation. We do co-treatments with physical therapy to actually help with that. We know as SLPs, the swallow and the breathing are very much linked together. So if they're not able to if they're not ready for swallowing, most likely they're not breathing correctly.
Right.
Well, and so no, it's gotten a lot better, and it's left to our discretion whether we follow the patient or if we need to back off. It's gotten when at the very beginning, I think you and I probably have the same amount of years of experience. It was difficult. Yeah, we would get, the initial consult and I was guilty of this as well. Seeing a patient, it's like, well, he was extubated just yesterday. We'll need to wait another day before we can jump in. Not anymore. Not anymore.
Yeah, now we know that's not true. Yeah. Yeah, no, and also I remember just being terrified because, it's crazy to me to think about. And I was telling, so I did a Parkinson's event over the weekend, and I was telling someone there that back when I worked at the trauma center, we would get consults on a patient, and I was one and a half. There was one and a half SLPs. There was one SLP that was split between acute care and outpatient, and then if I was covering, I was the only one for the whole campus, and we had 5 buildings. And so we had a heart hospital. We had about 4 ICUs, so general, a neuro, stroke, and trying to think of what the other.
Yeah, complex care or something like that.
Yeah, then a burn unit, the cancer center. I mean, and that would be like 12,000 steps at 11:30 a.m. So I'm way too old for that now. But it was a great, as stressful as it was a great learning experience because that's how I tried to look at, when I look back now, I'm like, how in the world did you do that, lady? Like, what in the world? But it was such a great learning experience. And again, it takes me back to learning more about holistic care for the patient and not isolating, okay, this patient needs more time before we could even get in the room. Now we know that, and it's evidence-based, that we get in there early, the better outcomes we have, when it comes to things like vent weaning, decannulation, and then also looking at, while we're working on those things, again, we go back to that cognitive function piece, and are they able to implement swallowing strategies, for example, or if we are at a point where we can do an instrumental exam for swallowing, are they able to follow basic directions? Or if we ask for them to do a breath hold, or we ask for them to, kind of stop for a second and take a break, are they able to do those things? Takes me back to, again, you mentioned emotional health, but also that psychological piece of, if they have an undocumented traumatic brain injury, where are they at on the Rancho scale? Are they having issues with impulse control? Whether it's not necessarily a physical thing, but it could be more of a, where they, I think you know what where I'm
Right.
going.
Yeah, it's so multifactorial, really.
Yeah, yeah,
And I think going back to the, how what kind of service and what are the benefits of having an SLP on the team early on. I think you may have had this Rachel Silvera on, who worked on developing trach teams,
Mhm.
and having an SLP actually at the helm of the trach team and what benefits that brings. I think her couple of papers that she's published, either as principal investigator or part of the team, and it really highlights and it's, again, it shows how valuable our services are to these patients and other populations who have respiratory compromised systems, uh, how well they do with us being involved early on. So again, respiratory goes into cognition. Cognition goes into their ability to live independently, or at least have a command of their care and direct it appropriately, which lessens the burden of care once they leave our doors. So you're seeing from, trauma through the acute phase into rehab and then going on to home health. We really are valuable. We I can't stress it enough, really.
Would you say that you felt like maybe you had to fight for that space? Because I
Oh,
don't think it didn't happen organically, right? You had to fight to be in that space.
yeah, I think, we didn't champion, we weren't the first in Miami, but I think we've definitely uh, sort of place this as such importance that it's really adopted. Like, I no longer have to chase a doctor to put an order. They know any SCIs that come through the doors, speech is consulted. That is
Mhm.
that is now part of the practice. And when new residents come through, that is something that is within when they're onboarded, that is something that they understand. In the trauma unit, we've done a lot of work in working with the trauma surgeons, and it's paid off because we really do have a presence there, but it wasn't always the case. I have to credit Craig Hospital over in Denver. They were the first who really came up with the idea of having an SLP uh, full time on the spinal cord injury rehab unit. They saw the benefits and actually started spreading the word. And one of the PTs and OTs actually sat in on the presentation that the SLP from Craig Hospital did, and brought that idea back to our unit in Miami. And it's taken off from there. So since 2018, it's been a work that we've done. And now I feel like, it's just sort of like has its own inertia.
Mhm.
People come in, speech pathology is consulted, and I get to assess how are they breathing, how are they swallowing, and how are they remembering and thinking, and then also bringing in the caregiver. It's not just the work of the SLP. It really does take the whole, like you were saying before, really the whole team. And then I like to say I help to support the education that's being taught.
And we do have a question, if the article is implementation of a speech language pathologist led tracheostomy team. And I would say, I think we both could answer this because we both know Rachel. Yeah, it's a really great article. And honestly, I recorded with Rachel in season 1 on the podcast, and we actually did her episode as a rewind this past week. So if you are interested in hearing more about that and learning more about trachs and vents, again, because trachs and vents go to so many other places: spinal cord injury, stroke rehab, TBI, even our cancer patients, our sometimes dementia patients. So it's a very well-rounded talk, and like learning more about that process. But one thing I wanted to mention and ask you about was when you talk about readmissions in this population, um, a lot of the readmissions, we kind of delved into wound care a little bit, but a lot of the readmissions are pulmonary related. Is that correct?
Yes, absolutely. You have readmissions for pneumonia.
Hmm.
You have readmissions. Those are typically what we see, a lot of wound and also respiratory failure. Absolutely.
Hmm.
Um, the we see the aging, the folks who were injured when they were younger, and as they get older, you have a lot of muscle atrophy, especially if they don't keep up with their health, right?
Hmm.
We get a lot of readmissions with pulmonary complications. Absolutely.
Yeah, and I mean, we're thinking about patients who are, you know, most likely wheelchair bound or at least wheelchair dependent for a good portion of their life, or even in some cases, if they don't have a good caregiver team when they leave the facility, they may even be bedbound.
Absolutely. Well, one of the things that we see with pulmonary complications is even like tidal volumes are significantly reduced, right? So this is how much air are you in quiet breathing? How much air are you inhaling and into your lungs? And when you think about, the diaphragm being a nice dome shape when it's healthy and getting all the signals, so through the spinal cord, it's nice. And when you're pulling in the air, you have a great displacement of the diaphragm, which allows you to pull in a really great amount of air or tidal volume. When you have the surrounding or the girdle muscles, I like to say, right? So
Mhm.
all the muscles of the core, when they are no longer toned because now there's paralysis, whatever degree of paralysis, there's a displacement of the diaphragm and of all of the visceral organs underneath the diaphragm. So you have, instead of a nice dome shape, you have more of a flat diaphragm. So their ability to, even in quiet breathing, to breathe as much air as they used to, as the normal tidal volume, is significantly decreased. So that's one issue, right?
Mhm.
Second issue, again, mentioning the core muscles, so the muscles around the belly and all the way around the back, those are no longer receiving the messages to keep the tone. And also, when you need to compress, they don't have access to or full access to the compression. What do we use the compression for? We need it to cough, right? We need to speak loudly, communication. We need to laugh. That's one thing in my research. One of the comments that I get is, "Oh my gosh, I'm laughing out loud," which was interesting to me the first time one of my patients, one of my research subjects said that to me. I was like, "Oh, yeah, I didn't think about that. You can laugh out loud." So all those things lead to a really weak system to begin with.
Mhm.
You're adding long-term spinal cord injury, you're adding aging. And if someone doesn't keep up with, their health, in other words, wellness, right? That all becomes more and more compromised. And that leads to readmissions to the hospital. So, they can't really protect themselves as well. If there's a cold or flu that comes through the family,
Yeah.
they're done for. Yeah.
Well, and then we also have the systemic barriers when it comes to access to care. We know insurance is an issue. We know that locale where you live can be a barrier to care. Overall health literacy is you know, if you are someone who experienced this injury, but your health literacy prior to was already low, and then now maybe you did have a cognitive impairment, maybe you didn't. Either way, if your health literacy isn't in line with what the hospital written education booklet they give you to take home. Maybe, I worked in a rural hospital for a long time, and that was a barrier for a lot of our patients across diagnosis was health literacy, access to food, all of those things that, we could consider our social determinants of health that a lot of people like to leave out because it's kind of the ugly side, if you will. But it's the true side, and it's the part where often we are SLPs, we have a voice, we have that advocacy piece. For some reason, we really like to shout it from the roof, which I love
The
because
other thing I
it's
like to add,
important.
yeah, the other thing I'd like to add is, the woman's issue as well. So,
Mhm,
if you're a woman, are you able to access a mammogram
mhm,
if you're in a wheelchair or if you have paralysis? Are you, when you go to the GYN, um, do you have the staff of the office? First of all, are you able to get on that table that's really high?
mhm,
Are they going to transfer you onto that table? Often, what I hear from the ladies in my group is that the staff in the doctor's offices are scared to move them. Uh,
mhm.
The tables are, we have to get on a platform to actually be able to sit on the table, and they can't do that. So there's a lot of, there's even added barriers for the ladies who do get injured. And yeah, so absolutely, there are a lot of barriers, and we as SLPs, as you said, actually sort of help with the development of the giving, I've done like script training with some of my patients to help them navigate through their care,
Mhm,
being able to teach them to um, direct their care. So
mhm.
if you are encountering this situation, let's practice on what you would need to say to be able to get through some of those barriers, or to direct their care. So yeah, for sure, this is part and parcel of what we do.
Yeah, no, and that's such a great point because, again, if it's a spinal cord injured patient who maybe also had surgery where there was hardware implanted, they need to be able to say, "I can't have an MRI because this isn't compatible," or "This is compatible." Remembering that they have this card
Mhm.
is, and I say this because my daughter had spinal surgery when she was young, and we had to carry a card around with pictures of her spine and what happened. But again, for her as a female, when she went to have her grandson, one of the barriers for her was she couldn't have an epidural, which is such a common procedure for pregnant women who are in labor. She couldn't have that, and so that was really traumatic for her. It was sort of a she's gonna kill me because, well, she doesn't listen, so it's fine. But it was very scary for her to uh, think about even having a child because she knew that pain management could be a problem. And it was a huge big deal. So that's, again, when we're thinking about someone who has a spinal cord injury, as a female, they may not even be able to have, you know, conceive. They may not be able to carry to term. But if they are, what does that look like? Because that could be a whole other podcast episode, honestly.
It really does. The great thing is, just as an aside, fertility is not negatively impacted in females after spinal cord injury. So that's always a really nice piece of news that I like to deliver to my younger ladies who have been injured. But for males, that's where the
Yeah.
impact is seen in that. So, but yeah, it's just everything is impacted. And the more they know, the more they're able to remember, and it just helps the independence going forward. So yeah, it's important. Can I say it again? We really do bring a lot of value. Speech pathologists, we just have a set of skills that the PTs and OTs do not possess.
Hmm.
Not to negatively, not to say anything
No.
bad about PTs and OTs. This is their world. This is where they shine. but we do too. We do really have a lot to help. Lot
Yeah, no, I agree with you. I think the work that you're doing is incredible. And, I really appreciate you sticking with me and being willing to come on and share this, because this is a lot of information that, again, I think a lot of SLPs and just general public, again, don't know the value of what we're able to do and how we're able to advocate. So we had one more question. Maybe a Craig Hospital resource. Is there another? I'm not sure what she's. I would have to click on this link. I'm not quite sure what. Let me see if I can click on this and see what it takes me to. Oh, it's the Craig Resource Library, Spinal Cord and Brain
Oh,
Injury
yeah,
Resource
they have
Library.
yeah, they do have a great resource library. The University of Washington also has a
Yeah.
great resource library as well. All the well-funded universities. So Shepherd also has a great
Yes.
its library as well. And yeah, those things are, and there are national agencies or foundations. So there's the uh, Christopher Reeves Foundation.
Yes.
There's a lot of educational materials that I use, and we include those in the booklets that the patients take along with them once they're discharged. The United Spine. So if anyone needs a mentor or a support group, United Spine can sort of connect you with local chapters. And I'm heavily involved in a support group here in South Florida, and have seen the impact of really connecting patients to community. And, there's a lot of things that we as therapists know from learning things from, our experience and also from books, but we do not have that lived experience. And those nuances we don't know anything about. So really helping patients sort of integrate into community is a really helpful thing. And we as speech pathologists do that really well. So if there's any other resources, but I think those are great places to start, really, to if you're interested in increasing your knowledge and understanding what we can bring to the table when working with these patients from the acute side all the way through the continuum of care. Those are great places to start. Absolutely.
Thank you so much, Stephanie. I really appreciate you being with us and, again, sharing your knowledge. Wish you continued success with your research and your initiatives. I know that it's a passion project for you. So, again, thank you so much for being with us.
You're very welcome. It was a pleasure. It was a pleasure.
Wonderful.
Hour went by really fast.
Thanks again, Stephanie. We look forward to seeing you again.
Thank you. I'm happy to come back anytime.